from Sarasota Memorial and the Deb Kavanaugh Multimedia Studio, this is HealthCast, a healthy dose of information from experts you can trust.
Hi, everybody. Welcome to HealthCast. I'm Allison Gottermeyer. Thank you so much for joining us today as we talk about benign prostatic hyperplasia, also known as BPH. Our guest today is Dr. Ramsey Kuo, a urologist with Sarasota Memorial's First Physicians Group. Dr. Kuo, thank you so much for joining us.
Allison, a pleasure being with you today to talk about this very important topic.
So let's start with the basics. What exactly is BPH and how common is it?
So in a nutshell, BPH is an enlargement of the prostate gland, which sits at the base of the bladder, conveniently around the urethra, which is the channel that carries the urine from the bladder to the outside world. And what happens is that with age or maturity, this prostate gland gets bigger, and it's a very common situation in men to have enlargement of this gland. And because of its anatomic location, it begins to cause obstruction of the outflow of urine from the bladder to the outside world and subsequent symptoms as a result.
Is it true that over 50% of men over the age of 60 have prostate enlargement with symptoms?
I would say that it is very common. 50% of men over the age of 60 begin to have some enlargement of the prostate gland, but there are factors that are involved with the onset of symptoms. So some men can develop fairly large glands and really have very minimal symptoms, but other men can have smaller or moderate degrees of enlargement, but many symptoms because it depends on the location of the enlargement and the impingement of the tissue upon where the bladder empties itself.
What does that actually mean for day-to-day life?
So what it ends up doing is creating a situation that affects men's quality of life in that the prostate starts getting larger. The first symptoms tend to be more, quote, obstructive, unquote, in that a man may notice that their stream is just not really as strong as it used to be. It may come out with more effort or start being intermittent, starting and stopping. And there's a sense of perhaps an incomplete emptying. Oh, I'm done urinating. Oh, maybe I can wait a few minutes and here comes some more urine that I can actually void. And so these are some of the initial symptoms that occur. And as time goes on, these symptoms may progress to more of what we call irritative voiding symptoms. In other words, you start having more frequency, going to the bathroom more often, maybe a little bit more urgency where you have that sensation of needing to go to urinate much more suddenly. Even a situation where if you wait a little bit too long, perhaps some leakage can occur because of that need to void all of a sudden that comes upon you. And I think this is all a spectrum of symptoms that develops because of the obstruction that the prostate starts causing.
It's my understanding that medication was the standard for managing BPH. Can you talk about how that came to be and why that model is starting to shift?
Absolutely. So interestingly, in the decades past, things shifted from a more surgical focus. For example, back in the 70s and 80s, maybe more transurethral resection of the prostate procedures were being done, which are the old-fashioned, quote, roto-rooters, which of course are still being done today and are really the gold standard procedures from an endoscopic standpoint. And back then, you also had open procedures to treat very large prostates, which required a large incision, tended to be associated with large amounts of blood loss and recovery times. In the 1990s, what happened is there was a significant paradigm shift where medications became available. The mainstay was what they term an alpha blocker. One of the best known alpha blockers is Flomax or tamsulosin, which results in the ability to relax the muscle tone of the prostate. And this allows the outflow resistance to be relieved to a degree to enable a man to be able to urinate with more force, empty more completely, and relieve some of these irritative voiding symptoms of urgency and frequency as a result. There's also another medication that tends to shrink the prostate to a degree to keep the prostate more stabilized in size. And so the shift in the 90s was, okay, well, we now have medications that can be used either singly or in combination to control these symptoms, and they became really the first line treatment options, shall we say, for symptoms from an enlarged prostate, and continue to be for many patients that type of option to go to first when they began having bothersome symptoms from prostate enlargement. However, as time has gone on more recently, what we've seen is that now there are many more technologies and procedures that are available that really have, frankly, expanded the toolbox, the armamentarium that the urologist has to treat enlargement of the prostate more actively. And as such, medications, while still an important part in the treatment options for enlarged prostates and subsequent symptoms, now I think becomes a little more compartmentalized. You don't have to think of medications as the be-all, end-all of treatment. It's only a part of treatment, but it's important to think about the fact that medications may have side effects. Oftentimes, alpha blockers can result in dizziness, lightheadedness. Some men also have some sexual side effects from these alpha blockers. And also these shrinkage medications similarly also have side effects as well. And the way to think about it is sometimes medications, while effective for symptoms, in a way you're kicking the can down the road. You're not really addressing the underlying situation aggressively enough. And so perhaps the prostate is going to continue to grow more slowly, but it's still going to end up causing a degree of obstruction over time. So it can still end up causing situations where it affects the bladder in a negative fashion. And that is where I think we've really kind of maybe gained a little more focus over time, in that we perhaps don't want to wait until the prostate becomes such a problem that the bladder ends up suffering and then causing some complications as a result of that.
We're going to talk about that a little bit, but you mentioned newer technologies and newer procedures. So I wanted to talk about what those are.
Sure, absolutely. And there's so many procedures now that take advantage of new approaches, new technologies. And the way to think about it now is that there are so many options that can now be tailored to a man's specific situation, depending on age, size of the prostate, degree of symptomatology. And so this is a situation where, for example, maybe a younger man who's in their 50s, early 60s, still very sexually active, may not want to have any significant side effects in terms of leakage and or sexual side effects, but doesn't want to have something done more invasively that may lead to some higher risks of side effects like maybe leakage of urine, sexual side effects. They may decide to focus on a less invasive procedure such as Resume, which is using steam vapor to basically treat the prostate earlier. And that might allow the symptoms to improve without the need for medications or to get off initial medication therapy. And then as time goes on, and perhaps other side effects like sexual functioning isn't maybe as important or first and foremost in your mind, then more complete procedures to remove the obstructing prostate might be something that can be turned to at a later date, for example. As we look at what's coming to the forefront now, there's lots of exciting new technologies available. Here at Sarasota Memorial, we offer the whole gamut of procedures that are utilized to really what I call extirpate or remove obstructing tissue from the gland when the gland has become quite large and really is causing a significant amount of blockage. And men often come in, they've exhausted medical therapy, they're really having a terrible quality of life because they're still up multiple times a night, they're not emptying the bladder, they're going way too often during the day, and when they want to go to void, they have to take a long time and a lot of time to end up emptying their bladders. And so in those types of cases, you definitely want to have something that's going to allow you to remove the tissue. The transurethral resection of the prostate, or TURP procedure, which is the old-fashioned Roto-Rooter, is still a mainstay in the urologist's armamentarium. But for very large prostates, procedures such as enucleation of the prostate, which provides you a very complete removal of the obstructing tissue with very little retreatment rate, is definitely a good option. Although that's kind of reserved for the more larger side of the spectrum when it comes to gland sizes. You can use the Da Vinci robotic system to perform what they call a simple prostatectomy, to remove the tissue minimally invasively when you have a very large prostate as well. But one of the most exciting developments, I think, recently has been the ability to perform what we term the aquablation procedure. And the aquablation procedure focuses on utilizing a high-power water jet internally that's delivered through a endoscope or a telescope inserted through the man's anatomy while they're under anesthesia, that allows you to ablate tissue and remove it very, very precisely, very carefully, and with very minimal side effects. And I think the exciting thing about this technology is that it utilizes robotic control, it utilizes artificial intelligence. What this platform utilizes is the anatomy from many different patients. The artificial intelligence algorithm is able to analyze the anatomy that you presented from a patient and basically suggest a treatment plan which you as a surgeon can basically look at and have the option of moving the target of the jet in many precise areas to hone what your treatment option is. And once you are satisfied with where the water jet is going to remove the tissue, it's a very reproducible, very, very safe option in that it uses very little heat energy, no heat energy, in fact, with the water jet. And once the water jet's done with tissue removal, what I usually do is go in, just do a little bit of, quote, cleanup to remove some of the leftover pulpy, if you will, or frondular tissue that's still involving the channel, just clean up and control bleeding points, and patients can usually go home the same day.
You talked a lot about different side effects that can happen from some of the other procedures. When talking to patients, how do you help them decide between all these options? Everything from medication to minimally invasive to the gold standard TURP procedures that are the sort of old-fashioned or original procedure. How do you help them decide what is right for them?
Well, that's a great question, Allison. I think what we have to do is really encourage men to make sure that they are not shy about sharing what types of symptoms they're having, because many times it's just, oh, you soldier on, you're doing okay. And oftentimes I'll have patients come in, hey, how often are you getting up at night? Oh, 5 or 6 times. Is that okay? Oh, yeah, it's great. But I think people just try to really be tough. They try to really put up with symptoms as long as they can because they feel, okay, I'm just not ready for anything invasive. But I think the way to think about it is these days, you don't want to get to a point where the prostate becomes such a problem that the bladder suffers, frankly, irreversible damage, because you have to think of the bladder as a pump. And the paradigm shift now is that you have perhaps stages of bladder failure you have to think about, much like the heart. You have congestive heart failure with the heart. You don't want to get to a point where your heart doesn't pump anymore because that's life-threatening. Well, guess what? The same thing can happen with the bladder. As the prostate gets larger, the bladder has to generate more force to overcome the resistance to enable you to expel the urine to the outside world. So it generates more force by having the muscle fibers in the bladder wall enlarge, and that's how it generates more squeeze and force. But with time, there's always trade-offs. Sure, the bladder can generate more squeeze, but what happens is that the bladder loses something in return, is that it basically loses its flexibility. It becomes less compliant over time, so it becomes stiffer as a result of the enlargement of the muscle fibers. And so what happens is more force is generated, but because the bladder ends up having muscle memory that it has to always end up squeezing very forcefully, what happens is the bladder becomes very ornery, very unstable, and spastic, and that's what leads to these urgency and frequency symptoms, because the bladder just wants to hold a certain amount of volume and then is used to squeezing the urine out very forcefully. So you end up having quite a few very negative symptoms. And once you pass that stage, you end up with a bladder that essentially loses its ability to squeeze. So it's like a pump that is working hard and working hard and working hard, and then one day it just stops working. And in your pool, for example, you can replace a pool pump, no problem. Replacing your bladder, that's a problem. No such thing. So you don't want to wait until you come in one day to the emergency room, not being able to urinate, having to have a catheter put in, and then having to say, I need something done yesterday now. It's something that we really have to get in front of. And how we help patients differentiate or perhaps talk about what options are available to them is we want to do appropriate evaluations. We want to perhaps have them come in, get an idea of how big their prostate is on an annual basis by feeling their prostate. We obviously can get more of an objective assessment by doing an ultrasound evaluation or even MRI evaluation of the prostate to get a very accurate volume of the prostate, to get an idea of, okay, how big is this gland and what types of treatments would fit for this size of gland. And there are also tests that can be done, either what we call urodynamics or even non-invasive tests like the urocuff for men, that can be done to help us define how obstructive things are and what their flow rate is, how fast the urine's exiting out of their body. And all those types of parameters can help us define how severe the situation is, and again, how, where in the line of the different options we can then focus on to really tailor the appropriate interventions for the individual patient.
What are the signs people should be aware of that bladder damage might already be happening?
So I think the issue is this. The thing to think about is first signs of something going maybe not in the right direction is slower stream, interrupted stream, maybe the inability to empty efficiently the first time around. When you get to the point where then that progresses to some frequency, going to the bathroom often at night, that's usually a sign the bladder is kind of struggling and has already tried to generate, again, increased force to push the urine through to the outside world, and now it's become a little stiffer, maybe losing some compliance. Maybe that's the time where, if that is the type of symptomatology that's presenting itself, maybe some additional testing should be done to just assess and figure out how obstructive things are. And I didn't mention this prior, but I think a cystoscopy sometimes can be very helpful too, because when you actually do a procedure where you actually look up into the anatomy through the penis and basically can assess the interior of the prostate to get an assessment of the degree of obstruction, that can be very important too, because as I've alluded to before, you don't have to necessarily have the biggest overall volume size to have significant obstruction. What I mean by that is it's also where the obstruction is taking place. Some men actually have a portion of the prostate growing up into the base of the bladder that then forms a, quote, flapper valve-like type of anatomy, which then results in a shelf or even a nodule of tissue basically sitting over the outlet. So when the bladder tries to empty itself, this shelf of tissue essentially physically blocks the outlet even more severely, and you can't really assess that with a digital rectal exam or easily with anything other than perhaps imaging or a direct look. And that's very important, I think, to kind of look at that type of anatomy, which then would need to be addressed by something to actually remove that tissue more actively.
So if you could communicate one key message to men over 50 about BPH and prostate health overall, what would it be?
I think the key message that I would like men to hear is that this is a natural, inevitable expectation that most men will have in their lives, and that the prostate is naturally going to enlarge with time. It's that when symptoms occur, don't ignore them and don't really try to brush them under the table. It's very important to be cognizant about what's going on and how truly it's affecting your life. If you are really going to the bathroom often, if you're on a trip and driving, and you know every rest area stop up and down I-75, for example, that's probably an issue that's telling you there's an issue, there's a problem here. And I think that I know that it's also natural to be avoidant of perhaps more aggressive procedures. No one in their right mind would be like, oh, I'm looking forward to a surgical procedure. But on the other hand, keep in mind that especially with the newer developments that we have today that we've talked about, there are procedures that can be done that are much less risky in terms of longer-term complications like leakage and sexual side effects that can also be very effective in treating the obstruction and relieving symptoms for a longer-term situation, and frankly enable you to get off the medications which may be causing side effects, or if some people are already taking 3 or 4 other medications for other medical issues, that's medications for your prostate that you no longer have to take.
You mentioned how far things have come. So my last question for you is, you've seen this shift in treatment of BPH. Where do you think the future of treatment is headed in the next 10, 15, 20 years?
I think as time goes on, there's always new technologies being evolved and created. And I think that as time goes on, I look forward to even more effective procedures being performed that can essentially treat the prostate and get rid of obstruction with even less side effects by being more focal and definitely less invasive as time goes on. That's just been the trend as time has gone on. And I think that we've definitely gotten to a point even today where with a minimally invasive water jet that can treat the prostate with no heat energy, really allow you to program what they term a protection zone near the tip of the prostate where the sphincter is to minimize incontinence and be very precise in terms of where that tissue is removed. And that's just exciting stuff. I'm just really amazed at how far we've come from even just 5-10 years ago. And I really feel that as time goes on, these types of technologies are just going to be refined even more and really allow treatment of prostate problems and enlargement and enable addressment of symptoms in a much earlier time with little side effects. And that's really the home run that we need.
Dr. Kuo, thank you so much for joining us and explaining all of this.
Well, I appreciate it, Allison. Thank you so much for having me here today.
If you liked this episode of HealthCasts, please like and comment and visit smh.com/podcast to listen to more experts like Dr. Kuo talking about the health issues which matter to you. As always, we encourage everyone in the community to visit smh.com to get the latest from Sarasota Memorial. Have a great day.